Hello, everyone, and thank you for joining us today for the October meeting of the HSS Myositis Support Group. We are honored to have with us today Dr. Michael Garshick, who will address the group on the topic of myositis and heart health. Dr. Garshick is an assistant professor in the cardio-rheumatology program at the Center for Prevention of Vascular Disease, the Leon H. Charney Division of Cardiology, and the Ronald O. Perlman Department of Dermatology, New York University Langone Health. Dr. Garshick's research interests include exploring mechanisms to explain the heightened risk of cardiovascular disease in patients with immune-mediated inflammatory diseases, with a specific focus on platelet activation and endothelial cell damage in patients with psoriasis. He conducts clinical trials and directs the cardio-rheumatology program at NYU Langone Health, dedicated to reducing cardiovascular risk in patients with heightened systemic inflammation. Dr. Garshick has held grants from the New York Medical Society, National Psoriasis Foundation, Dermatology Foundation, American Heart Association, and National Institute of Health, National Lung, Heart, and Blood Institute. Questions will be answered after Dr. Garshick's presentation. Please enter your questions in the chat box at the bottom of your screen. You'll also have the opportunity to ask questions directly, as the recording will have stopped at that point. I'd like to thank you, Dr. Garshick, for joining us.
Thank you for the introduction and the opportunity to speak today. It's a real pleasure. I am going to start the presentation. You can certainly feel free to interrupt me or to do whatever you want to do in terms of getting questions across. And as it has to say, I cannot give medical advice based on your condition specifically, but of course, I'm happy to give my general overall gestalt and thoughts. And one other caveat is I am not a rheumatologist, I am a cardiologist. So I have an interest in managing heart disease, but I do not specifically manage the actual autoimmune conditions. I manage the cardiovascular heart disease complications from those conditions. And these are my disclosures, which aren't related to the topic today. I wanted to start the afternoon with actually a clinical case of someone who we may see in our cardio-rheumatology program. So this is a 68-year-old female. She has dermatomyositis. She has high blood pressure. And she was referred to clinic after a CT scan of the head for headache, for whatever reason, demonstrated actually an old stroke, CVA. So in terms of her history, she's had dermatomyositis for about 12, 13 years. She was initially treated with pretty powerful systemic medications, prednisone, high dose of prednisone of steroids. She was given something else called Plaquenil. She was then switched to another medication, methotrexate. And I'm assuming, given the audience, many of you are probably more familiar with these medications than I am, frankly. And then she developed a headache. And then when she had the headache, she then got a head CT, which led to a CT scan of the head. And they noticed this old stroke. She's known to have high blood pressure and high cholesterol. Now, whenever anybody has an old stroke, regardless of the mechanism, we assume that it's from potentially cholesterol buildup in the arteries. And one of the core things that we do is we give cholesterol-lowering medication. It almost doesn't matter what your cholesterol is. If you've had a stroke, we do everything in our power to prevent that stroke from reoccurring. But, as is the case in many patients with myositis or inflammation in the muscles, she had tried a cholesterol pill, but she failed. Her muscle pain got worse. And these are her and so she was off a cholesterol pill when she came to see us in cardio-rheumatology clinic, despite really needing one. Now, her cholesterol, this is a profile right here. I'm not going to go much into depth in this case. I just want to get a sense that her cholesterol is, this number 102 is actually not that high. She didn't have diabetes. Okay. So as part of her workup, and we're going to talk about this test, she underwent a CT scan of her heart. And the CT scan of her heart was meant to look at her blood vessels feeding the heart. And they noted a lot of cholesterol buildup on that CT scan, quite high. So this case, I think, highlights someone who we may see in our cardio-rheumatology program, someone who has inflammation of she has myositis. She's got cholesterol buildup in her heart, in the blood vessels in her heart. She's had an old stroke, yet she couldn't tolerate cholesterol-lowering medications, a key treatment to prevent this from happening again. And so the decision was, well, what to do about it? So we're going to really unpack this case, and I'm going to really frame all the testing we talked about, as well as why it's so important to really aggressively manage risk factors and also aggressively manage cholesterol buildup in the heart of patients with myositis. So, okay, so what is the heart? And you can stop me if I'm being way too basic, but I really wanted to start from ground one and kind of build it up. So the heart is a constantly moving muscle in our body. And what happens is the blood flow comes in from either your legs or your brain into the right side of the heart, goes down to the lower right chamber of the heart called the right ventricle. That right ventricle then pumps blood to the lungs, and the lungs provide oxygen. Then the blood, once it gets oxygen, goes back to the left side of the heart, the left atrium, the left ventricle, and it pumps blood out to the rest of your body. Now, your heart needs energy. It needs oxygen. It needs nutrients. It needs its own blood. And it doesn't necessarily get blood from pumping blood. It gets blood from actually the coronary arteries, the blood vessels that feed blood flow to the heart itself and provide energy to the muscle. And there are three main coronary arteries: the left coronary artery, the left circumflex, and the right coronary artery. When you have chest pain, when you have a heart attack, the same process when it happens in the brain is considered a stroke. What happens is the cholesterol buildup, that's this yellow, actually goes into the blood vessel wall, and it starts to close up in this blood vessel wall. If it closes up slowly, while you're limiting the blood flow to the heart, that causes chest pain. If it closes up fast, that's considered a heart attack. Now, in a patient, why did I go through the background of the heart being a muscle, which I'm sure you are aware of, that the heart needs blood flow, its own blood flow supply to work? Well, because when a cardiologist hears myositis, a whole host of things can be happening in the heart that can affect the muscle, can affect the cholesterol buildup in the arteries. So what can happen in a patient with myositis? Well, the heart has an electrical system that allows it to pump, so you can get what we call arrhythmias, or extra electrical beats on the top part of the bottom part of the heart. The heart muscle itself can be inflamed, similar to your leg muscles. That can create inflammation or immune cells inside your heart. It can create scarring in your heart. You can also get cholesterol buildup in the arteries in a patient with myositis. Again, that can cause chest pain, heart attacks, and even cause the heart itself to be weak. So we're going to focus on two things in myositis patients today: the limitation of blood flow to the heart, the cholesterol buildup in the coronary arteries. And we're also going to focus on inflammation of the heart muscle itself, leading to scar. And I promise I have a happy ending after all this. Okay. So first of all, again, we know myositis is inflammation of the muscle. This is from a case report that a well-known rheumatologist who does this a lot in California published. It's actually a patient of hers from several years ago. She biopsied the muscle, and this is a thigh muscle. Now, and I want to point you to figure B. You can see these nice, healthy pink muscle fibers. They look big and plump and round. And there's a surrounding blue surrounding each of the muscles. Those are just little tiny bits of cells surrounding it. Then if you go to the screen right, you can see a lot of infiltrates of blue, kind of compressing those muscle fibers, causing the muscle fibers to become destroyed. That's actually active inflammation or active immune cells attacking the muscle fibers. And you can see a distinct difference between the healthy muscle, kind of at the top left of the figure, and the damaged muscle in the bottom right. So what she did is this patient actually got very, very sick. They needed their heart replaced. Well, she wanted to prove, so she actually took, once that heart was replaced, and I'm really summarizing a very dramatic thing that happened to this patient, and really very, very quite rare, but it provided an opportunity to actually look at the heart muscle itself. You don't get very many of these opportunities because biopsying a heart is actually kind of complex. You don't really know where you're biopsying the muscle, so it's kind of blindly going in and taking stuff. But if someone ever has their heart replaced, you can really analyze that entire heart. So what she showed is that that same inflammation process that was happening in the muscle, and that's that circle process here, was also happening in the heart. This infiltration of immune cells, really showing for one of the first times a connection, even though we kind of, MRIs had suggested this, ultrasounds of the heart had suggested this, but she had biopsy proven that the same cells that were attacking the leg muscles were also attacking the heart muscles. And the frequency, unfortunately, because this is so, the condition, as you know, myositis is relatively rare and patients aren't that frequent. We don't come across patients that frequently. It can make it very, very hard to study. And you see here this ridiculously wide frequency between the connection between those that are having leg issues and heart issues, anywhere between 9 to 72% of patients. Whenever you see that much of a discrepancy in frequency, it means we still don't really know what we're doing, and we still are having a lot of time figuring out the true prevalence, the true nature of how often myositis patients have involvement of their heart muscle. Okay. But of course, that begs a question. If we treat, does your myocarditis get better, right? That's what we all want to know. If you are having either clinical or subclinical, meaning if there's inflammation, immune systems attacking your heart, if we treat, does it get better? Well, one of the best tests we can give patients to figure out is the heart involved is a cardiac MRI. So cardiac MRI is not a fun exam. You go into a scan. I'm sure you've all had them before. Many of you have probably had them. They can be somewhat long. You go into a very small tube, and there's lots of pulsating and vibrating for sometimes 20 minutes, 30 minutes, hours on end. And a cardiac MRI can be somewhat intense, but it can be really, really useful because we can figure out, do you have any inflammation in your heart? Is there any scar in your heart? Is your heart weak or is it strong? So this was a study where they took 44 patients with myositis, and those patients got MRIs of their heart. Now, let me walk you through this table. This is a table of those 44 patients that got MRIs of their heart with myositis. They're middle-aged, around 49, 50% male. They were normal weight, and they had relatively controlled blood pressures and heart rates. This is their presentation. Almost all of them, of course, had muscle weakness. 65% had rashes, 52% had muscle aches. There was some difficulty swallowing as well. And they not only compared these cardiac MRIs of patients with myositis, but also to healthy controls. So in those 44 patients, 28 actually underwent repeat cardiac MRI 14 months later. So I'm going to walk you through these figures. The y-axis, that long axis, it doesn't matter really if you can understand this number or not. Just kind of understand that on this y-axis, these are outcome measures from cardiac MRI. And each graph shows a different measurement of some sort of heart function that was obtained from the MRI. And you can see here, let's go to figure 4. This value right here is a normal controls. This is the baseline in the middle, and this is the follow-up time point. So we have the healthy controls, the people without myositis. Then we have the patients in the middle on figure 4 here that had myositis before they were treated. And then there are patients with myositis after the treatment. And what you can see here is that value got better. And every single measure of cardiac function on MRI got better after treatment of their myositis. Now, it didn't go back down to the values of a healthy control, but at least it got better. This is only after a year or so of treatment. So we still have much, much more time to go. So we said that in many cases, we think that if you have myositis and if you have involvement of your heart, this suggests that potentially treatment of the myositis can make your heart function better. Okay. So that's how the heart can impact, that's how myositis can impact the heart muscle. But then there's this whole area emerging of how patients who have inflammation, how that affects the blood vessels of the heart. And I'm going to go into this in a lot of detail. So first of all, are patients with myositis at risk of developing a heart attack or stroke over time? And the answer is potentially yes. This is a review article from 2017. So review articles are actually one way that someone out there who's an expert in the field can summarize all the data. In 2017 may seem like a long time ago, but this is still considered relatively recent in medical terminology. These are polymyositis and dermatomyositis patients. And I'll adjust I'll have your eyes go down to what we call the hazard ratio, which is at HR, and that number 5.2, 3.89. And what this graph tells us that patients with polymyositis and dermatomyositis, when compared to non-myositis patients, have a 3 to 4-fold higher rate of developing heart cholesterol buildup in their arteries when compared to those without. Now, the study also looked at the risk of blood clots. Well, it turns out, again, I'll direct your number to that 7, that 6, and that 7. Patients with polymyositis and dermatomyositis have a higher risk of blood clots as well. So all this can be quite scary, but then I want to walk you through what we're doing to try to help this problem and really kind of give some strong, rationale why it's important, and what you can do to prevent this from occurring. So first, I want to go into more granular detail of how do heart attacks occur. Well, again, heart attacks is that cholesterol buildup in the arteries. But how does cholesterol buildup occur, and why do cardiologists care about cholesterol? Okay, so this is a section of the blood vessel. Essentially, the blood is floating around in that white at top, and then the blood vessels at the bottom. So first, we really believe you need cholesterol. What happens is the blood vessel gets damaged. That's the endothelial cells. Once the blood vessel gets damaged, the cholesterol particles can go through. Well, how does the blood vessel wall get damaged? The biggest risk factor is actually age. Can't beat it. Just exposure to stuff over time. That's why patients who are older are higher risk for heart problems. Then it's also things like smoking, those toxins damage the blood vessel. High blood pressure damages the blood vessel wall. Diabetes can damage the blood vessel wall. But also immune system overactivation. The same immune cells that are attacking, say, your skin or your joints and your muscle can also attack that blood vessel wall. So once that blood vessel wall gets damaged, it allows the cholesterol to go through into the blood vessel wall space. Then it starts to build up over time. Your immune system tries to attack that cholesterol. It says that cholesterol is not supposed to be there. I'm going to get it out. However, in the process of your immune system attacking the cholesterol, it actually makes it worse. So you can imagine anybody with an overactivated immune system, not only does it damage the blood vessel wall, but it also it's attacking the cholesterol more once it goes into the wall. And that's how cholesterol buildup can occur in heart and blood vessels in patients with immune conditions. Now, I recognize this figure is not about a myositis, but it's actually a framework of how we think about many of our immune diseases, where it's the combination of the traditional heart disease risk factors, and I'm going to get into that first, combined with the immune-specific variables that are felt to be the inflammation in patients with autoimmune conditions, and that then leads to blood vessel wall damage and heart disease buildup. So then, if we see a patient, it doesn't matter if they have immune disease or no immune disease. When we see them in our office, how do we think about them? Well, everybody should first have their heart disease risk calculated. So we first want to know, what is your risk of having a heart problem over the next 10 years, of having a heart attack or stroke? So we take your age, your sex, race, your blood pressure, your cholesterol, and we put into a risk calculator. It's as simple as that. It may sound complex, but primary care doctors are supposed to be doing this at every single appointment, figuring out what is your risk, your 10-year risk of having a heart attack or stroke. And then we put you into this algorithm. Are you over 21 years old? Are you a candidate for any types of cholesterol-lowering therapy? Have you ever had a heart attack? Is your cholesterol ridiculously high? Do you have diabetes? If none of these are you, if you have diabetes, you automatically should be doing something about your overall heart health. But let's say you don't have diabetes. Well, then we put you into this rubric. We say, what is your risk? I'll direct you to the top right of having a heart problem over the next 10 years. Is it 5%, 7%, greater than 7%, or between 5 and 7%? So all we do is we take a risk calculator, we put in your age, your sex, your cholesterol, your blood pressure. We figure out what is your risk of having a heart problem later in life, 10 years. Now, an amazing thing happened in 2018. Our heart disease guidelines actually said that we should start incorporating patients with underlying inflammation into figuring out your risk. This was the first time in the history of cardiology that we were said, hey, take someone who has a risk of having a heart problem and actually then start factoring in their overall inflammation status. Now, based on your inflammation status and your overall 10-year risk, we then try to figure out how aggressive we should be about management, how aggressive we should be about managing your blood pressure, your cholesterol, your immune system. So in patients with immune-mediated diseases, they have a lot of stuff going on, and this is actually a particular passion of mine. You guys are you're seeing a lot of doctors, right? You have a lot of complex conversations with your rheumatologist, your dermatologist. There may not be enough time to talk about general overall heart disease prevention. What's your blood pressure? What's your cholesterol? What are your diabetes status? So in our cardio-rheumatology clinic, we actually spend a lot of time not focusing so much on your autoimmune disease, because we figure you have a relationship with your rheumatologist and your dermatologist, but we want to talk about the stuff that is less commonly talked about, but really, really important. The common things that really will hurt you: blood pressure, cholesterol, things that if we manage, take your higher risk and put you back down to normal. So we first focus on the cholesterol, the blood pressure, we calculate these risk scores, and then we figure out what types of prevention medications you need to be on to reduce risk. But then we also try to figure out, well, are there unique factors in your life that are increasing your risk even more? Well, steroids. High-dose steroids can also increase your risk, cause fluid retention, electrical issues, high glucose. I'm sure many of you have probably been on high-dose steroids. That generally is a key component for the first-line treatment of different myositis. So we take that into account as well to try to figure out, based on your exposure, does that increase your risk even more? And why is this so important? Well, turns out traditional risk factors are actually higher in patients with myositis: high blood pressure, diabetes, and coronary artery calcification. So we spoke about that earlier, that our patient with dermatomyositis had a lot of coronary artery calcification. Well, what is that? Okay, what is coronary? So a common prevention strategy that we do across any patient, whether they have an immune condition or not, is obtaining a coronary artery calcium score. So a calcium score is a low radiation CT scan of the chest focused on just your blood vessels, the coronary arteries. And if you remember, I spoke about how cholesterol buildup occurs over time. Well, calcium buildup is that last stage of cholesterol buildup in the arteries. Just because you have calcium buildup, it doesn't mean you have a bad blockage. The calcium builds up on the outside of the blood vessels, not the inside, but it's a marker. It's a marker of things going on inside that we can't see. So actually, in our guidelines, and a very common test that we do is a calcium score, because if we see the calcium, it means that cholesterol buildup has occurred, and we should do everything in our power to reduce that as much as humanly possible. So control blood pressure, control calcium, control diabetes status, control weight, and control your myositis as well. So really, when we think about recognizing overall heart disease risk and autoimmunity, I think about through several different mechanisms: lifestyle, smoking, diet, physical activity, depression, the comorbidities that can come with a lot of these immune-mediated conditions or inflammatory conditions: high blood pressure, high cholesterol. We do risk scores. We look at your disease activity. How active is it? Because the more active the myositis, the more at risk you are. we treat your traditional risk factors, and of course, we want to make sure you're on good immune modulating therapy to reduce your myositis. Well, as I said, I'm not a rheumatologist, I'm a cardiologist, but there are actually rheumatologists that are real specialized and experts at patients with myositis. And this physician, about 11 years ago, surveyed 63 myositis centers across the world. She wanted to know, are people actually focusing on the traditional heart disease risk factors in these expert centers, these centers that really have a expertise at dealing with patients with myositis? Well, first of all, who were the patients seeing these experts? This is that figure on the left. Well, it turns out 50% of patients with myositis being seen at these expert centers had had a heart attack or stroke, and then 60 to 70% had had some sort of heart disease involvement. And then these expert centers, these patients who are being seen at these expert centers, only 50% were getting the cholesterol checked. Now, that may seem terrible to you, and I'd argue we should do much better. But actually, compared to other patient populations, 50% is actually pretty good. In psoriasis, it's like almost zero that the dermatologists are checking cholesterol. So while we have a lot of work to go, I would say this is actually pretty good and indicative of the types of care that many of these patients were getting, but I would argue it could be better. Then, how many of these patients were on different strategies to reduce risk? Well, almost 80% were on some sort of cholesterol-lowering therapy. The majority were on cholesterol-lowering medications. And then some of them, then a lot of these providers seemed like they had a lot of experience managing the cholesterol issues. 70% had greater than 5 patients on some sort of lipid-lowering strategy. So I'd argue that while we still have a lot of work to do, there is a recognition in the myositis community that as a whole, that the patients with myositis should have their risk factors aggressively managed. Now, I want to talk about a common concern or common thing that happens in many patients with myositis. There are a lot of muscle issues. Well, as soon as you Google statins and side effects, you'll come across muscle cramps, muscle aches, muscle pain. And frankly, it doesn't matter if they're real, not real. If they are real to you, then they are really happening. And the problem is, if they're real to you and they're really happening, we can't get you on appropriate cholesterol-lowering medications, a key component of heart disease prevention. And so this intolerance thing comes up again and again and again. And what I argue now in 2023 is, if you want to be on a cholesterol-lowering medication, we will get you on something. It does not matter if you don't tolerate a statin, we will find something that works for you. So first of all, we do check to make sure there's no intolerance. Obviously, if you've had a significant interaction, if you've had some sort of necrotizing myopathy from a statin, which is ridiculously rare, but I recognize I'm speaking to a very special group here tonight, you will never be on a statin again, and that's okay. We have other medications for you, but we have all sorts of tricks and tips and techniques to try to get you on a cholesterol-lowering medication. And the reason this is so important is if you are very high risk for a heart problem, if you have an immune-mediated condition, we want to get your cholesterol low, under 750 milligrams per deciliter in general. So finally, not just do we want to focus on heart disease prevention and cholesterol-lowering medication in patients with myositis, I wanted to highlight some of the work we're doing in my laboratory. The question comes up, if we treat your myositis, will the involvement of the myositis in the heart muscle get better? And there's a good chance that yes, it could. But if we treat your myositis, will your risk of a heart attack or stroke actually be decreased over time? This is data we presented in an abstract. It's under review in some journals right now. But this was a pretty large study for patients with dermatomyositis. This is just dermatomyositis and polymyositis. And it's evaluating over 200 individuals. This is considered huge in dermatomyositis, polymyositis world. And I'll focus your attention on the graph, the blue and the red, light blue. The blue is the patients that got immune modulating medications, so immunosuppressive medications, not just prednisone, but say methotrexate, cyclosporin, or Cytoxan. The red is patients who got prednisone, but nothing else. They got no other disease-modifying agents. And when you see over time, that blue line is higher than the red line. So the patients who got Steroid-sparing medications actually had a lower rate of heart attack and stroke over time than those that did not, suggesting that there's a lot of good reason to get you on some sort of long therapy, durable medication for your myositis. So let's go back to our patient. Well, she had dermatomyositis, she had muscle cramps, but she had a very high calcium score. She had a lot of buildup in her blood vessels feeding her heart. She could not tolerate a statin. This is rosuvastatin and Crestor. Pitavastatin, one of our best tolerated statins. She couldn't tolerate it. I would argue this is a little outdated because ezetimibe is something that's another cholesterol medication that's a little less powerful. And we would actually jump to something else in this case. So what do we do now? Well, we now have these injectable medications called PCSK9 inhibitors. You inject them either once every other week or once a month. They do not cause muscle aches or cramps or pains. They do not cause muscle breakdown. And as it turns out, in 2023, it is actually, if you have a high calcium score, if you've had a prior heart disease or stroke, it is very easy for the majority of plans to get this approved. There does become a problem sometimes in terms of how the supplement acts with it, but there are patient coupons, and we have a lot of strategies to try to help you. So for this patient, she got started on this Repatha, this PCSK9 inhibitor. Her cholesterol was very, very low. Her dermatomyositis was being treated, and she felt well. Okay, so again, I wanted to end with this rubric of how we think about patients with immune-mediated conditions, where it's first we talk about lifestyle screening and the traditional risk factors. We calculate that risk score. We look at your disease activity, and we focus on treating the traditional heart disease risk factors, in addition to what types of immune modulating therapies you're on and how they may impact your disease and your overall heart disease risk.